Afternoon now, so we'll go ahead and get started. Um, I'm going to be Teresa Sevilis, and I'm going to be talking with you guys about Alteplase to treat or not to treat is our discussion today. To start by just saying a little bit about me, I'm a board certified neurology and vascular neurologist, and I did my vascular fellowship at UNC Chapel Hill. I've been with telespecialists since 2017. And I'm one of the regional medical directors, so I work a lot with the quality program, and I'm sure I've reached out to quite a few of you through that and discussing cases and various things that we bring up. So that's a little about me. I have nothing to disclose here, and a little overview of what we're going to talk about today. We're going to talk about some of the variations in practice with treating with TPA, as well as the indications and contraindications. I wanted to start off with just saying, to treat or not to treat is very much a complicated question. While we can try to make it really simple and say there's a right or wrong answer, in some situations there is, but there's also a lot of variability in comfort level and thought processes, and a lot of lack of solid evidence in acute stroke care. And so people do treat differently. This is a chart from a paper written back in 2016 that I always thought was very interesting because it shows you up to 50% variability when asking neurologists if they would treat patients. In that case, it was a secured aneurysm down to zero variability in treating an INR greater than 1.7. Now, it's just a survey that was given, but it can show you kind of the extent of differences and care of different neurologists. And really, when we're making this Alteplase decision, we are thinking about what's this patient's risk of bleeding versus what's their risk of disability. What impact is this going to truly have on the rest of their life versus are we going to cause them to have a fatal bleed in which they won't have a rest of their life and then it wouldn't really matter. And that can really be a balancing act sometimes, and it requires a lot of thought on our part as well as patient input and really what their goals of care are. So I decided the best way to try to go through all this is, and not miss any of the key points, is to kind of go through the guidelines. This particular table, table 8 in the guidelines, really gives you a nice quick reference for what we have data for, what we don't, and kind of can help guide you with treatment. Now, the thing with the guidelines is they don't give you the answer. You can't necessarily come here and say, okay, this is clearly what I should do today, versus what not to do. It's not going to tell you exactly about your individual patient, but they can certainly give you some strong indications as to what the best choice is and help guide the decision-making process. So just kind of the way I think of this particular chart is you have your green, which is your indications. To me, is the green light to treat. These are slam dunk, easy cases that there really isn't a lot of question about because we do have a lot of strong data. And in order to make it into this category, there's a strong body of evidence that leads it to be an indication. So those things that fall into here would be a patient greater than 18 years of age within the 3-hour time window. That is a clear indication to treat. And you can see here when we're talking about the 3-hour time window, all the ECAS criteria are not included here, ECAS 3. Those are all patients we should still be treating within this 3-hour window because we have strong evidence for that. The one thing that I do want to bring out a little bit here is the discussion of glucose. The green light here is to treat everybody with the glucose over 50. The little later you can see in the kind of yellow light or questionable area where they do mention that greater than 500 number again. But at this point, we're saying there is an indication to treat greater than 50. And the real reason for that is that if you have a patient with a glucose over 400, you're getting an insulin drip started, taking the time to get that all done, as well as the time to wait and see if they improve. Even if they don't improve, it doesn't mean it's not stroke symptoms, because sometimes there can be delay in improvement. So the time that it would really take to do all of that makes it very difficult to treat a patient within the IV TPA window of 4.5 hours. So that kind of process of going through all that is really going to say that you're just not treating them. So it kind of falls more into that stroke mimic category. And I tend to go by this guideline right here that tells us anything greater than 50, you can go ahead and treat as long as it is suspected to be a stroke. Treating somebody with a glucose less than 50, giving them some glucose, the likelihood of you getting them above quickly is there. It's just a lot harder with the greater than 400s. Most of these other things I don't think we really need to go through. Getting the head CT, we know that we can treat patients that are on antiplatelets. End stage renal disease, if you know that they have abnormal coagulation, if they have an elevated PTT, then you shouldn't be treating them. But in most situations, we're not necessarily going to know that, and it's reasonable to start treating them and stop if their labs came back abnormal. So I wouldn't delay if you didn't know that normal, unless you know that they actually have the history of having abnormal studies. And then these kind of yellow-orange area here is saying that we have moderate evidence. So that really varies in what we consider moderate. Sometimes it's anything from expert opinion to case studies to small literature review series. And we're going to get much more detailed on all of these. And this continues to be that yellow area. And then we get to the red section. And the red section is your stoplight. These are the things that we know are harmful. We know that we don't want to treat. And so they get that red light there. So as we're going through here, we're going to also do some cases to try to make this a little more interesting and interactive for everyone. So this is our first case. And just to know how they're going to go here is we're going to get a little pop-up where you guys can pick yes or no if you would treat. It is going to cover part of the question. And EJ is going to help me out here because I'm not going to be able to see your answers while I'm presenting, and just let me know the percentages of answers, and then we can go on from there. So the first question is, we have a 103-year-old male with a history of AFib, not on anticoagulation, who's presenting with 2 hours of speech changes and right-sided weakness with an NIH of 12. Would you treat this patient with IV Alteplase?
All right, the votes are coming in. We'll give it just another second. And it looks like we have 90% saying yes and 10% saying no.
Okay. So as far as the age portion of the guidelines, the 2019 update to the guidelines, we're looking at treating all patients over the age of 18 within the 3-hour time window. So this would include our 103-year-old. This really includes somebody to any age in that 3-hour window that we have no reason to exclude them. Now, we do know that patients grow older than 80 are not likely to do as well as patients less than 80, simply because of their age. So when making this decision, it's comparing their outcomes to someone in the same group. If we compare those who didn't get treated at 90 to someone who did get treated at 90, that's a much better comparison than expecting them to do as well as somebody who was 75 or 60. Now, there is different studies that did include some patients. We don't have high volumes of patients over 80 because they do tend to get excluded from a lot of the studies. But there is one meta-analysis of 6 studies with a 3-hour time window that did show 96 more patients alive and independent per 1,000 patients greater than 80, and 95 per 1,000 patients less than 80 who are alive and independent after TPA, which is really about the same. And that's, again, meta-analysis, not randomized controlled studies, but it's enough to give us the idea that we are still improving the quality of life and benefiting these patients who are over 80. And so that's where the 3 to 4.5 hour window is even now considered safe and potentially effective, maybe not as effective as younger patients again. And we also can't really compare that 3 to 4.5 hour window to the less than 3, simply because we know the longer you are out from stroke symptoms, the less likely you are to have as good of an outcome, regardless of your age. But based on the guidelines right now, anyone over 18, even within the 4.5 hour window, should be considered for IV TPA. Then we're going to get a little more into the time window here. And really, these are all the ECAS-3 criteria that we're excluding people from the 3 to 4.5 hour time window. And various different meta-analysis, literature reviews have really gotten us to the point where it's hard to really continue to exclude all of these people from the 3 to 4.5 hour window, because they may not do as well, again, simply because they're in that time window. Now, age we just discussed, the diabetes and prior stroke, there really is no direct data just looking at those two variables impact on how somebody's outcome would be. So it's reasonable to think that it would be just as effective as in the 0 to 3 hour window, when you're taking into account the fact that you are getting further from symptom onset and, again, less likely to improve simply because of the time period. Now, severe strokes, we know severe stroke just in and of itself is less likely to improve, whether you do it in the 0 to 3, the 3 to 4.5 window. And in a lot of situations, those patients simply do need thrombectomy. But at this point, saying that they don't get TPA because of that is not the route that we're going. We should still be giving the TPA despite moving on to the thrombectomy. And the last one, the mild disabling stroke, again, it's reasonable to consider these patients within the 3 to 4.5 hour window as well, because we don't have a lot of data to say that they won't do any better. And just kind of as a side note, when you're thinking about the time window, is not, I didn't know this until I had looked it up during my fellowship time, was really where did the 3 hour window come from? And the 3 hour window actually came from primate studies in which they blocked off the MCA and found permanent damage in a 2 to 3 hour range. And that's where we're getting this from. So it's not hard and solid fact that you're going to have that completed stroke by the 3 hours. And we've all seen that there's a big variability with collateral flow and which patients are going to do well, some that can last longer, some that can't. And we really can't predict that early on. So we should at least be considering everyone in the 4.5 hour window. Now, if they have every one of these things against them and they're very old and unlikely to recover and their family doesn't want to be treated, that's one thing. But the discussions and the thought process should certainly be there for all patients within the 4.5 hour window who are greater than 18. Next, we're going to talk, still in the time window, about wake-up strokes. So there are some more recent changes with wake-up strokes, and now we can consider treating patients within 4.5 hours of symptom recognition. So the Wake Up trial was randomized with 503 patients, and these were patients who awoke with stroke symptoms and had an unclear onset time. And they treated them within 4.5 hours of when those symptoms were recognized, or when they were waking up in this case. And so the criteria to treat these patients was MRI mismatch, meaning that there was abnormal signal on the DWI and no visible changes on FLAIR. Other exclusions were a DWI lesion larger than a third of the MCA territory, NIH stroke scale greater than 25, any other contraindications to TPA, or a planned thrombectomy. So the study was stopped early. They were trying to get 800 patients, which they did not reach, but it did still show an MRS of 0 to 1 at 90 days in 53.3% of the patients who received Alteplase and 41.8% in the placebo group. So this does show that it can be effective with these right protocols in place. Now, this is not something that we can feasibly do at every hospital. Most places can't get an MRI that quickly. We do have the Altru going up and going with a kind of pilot of our ability to be able to do this right now. But down the line, I think it may become more and more feasible eventually. And here is our next question. So we have a 82-year-old female with history of dementia who's living in a nursing facility who's presenting with left gaze, right-sided weakness, and aphasia. Last normal was 2 hours ago, confirmed with the nursing facility. Her baseline is she's wheelchair bound, but able to carry on simple conversations, and the family wants to do everything to maintain her current state if possible. Would you treat with IV Alteplase?
For this one, we had 100% yes.
Okay. Okay, so pre-existing disability. And, this is sometimes somewhat controversial because you're not going to get somebody who was an MRS of 3 to an MRS of 0, obviously, because they weren't there in the first place. But it doesn't mean that they don't have quality of life that's worth saving. And the way of knowing that is really the discussion with the family. What we may consider a poor quality of life may very well not be for that family and for the patient. If they can interact, have some quality time together and be there, and they want to preserve that, who are we to judge that they're too disabled to be worth trying to save? So I'm happy to see that one's 100% and that we're all in agreement that we would give people the chance that they want to have. And so it's just again conversations. It's do they have the support? Does the family understand what disabilities they may have from the stroke, what disabilities they may have despite treatment of the stroke, and really just assessing their goals of care. As I find a lot of patients in that older, already disabled place would either want to interact and do what they can or not be here anymore. And that bleed risk doesn't scare them as much because they wouldn't want to have the hemiplegic aphasic type of life. And so again, there's not a ton of data on this. As I just said, we can't get better than we were, but the data that we do have doesn't show increase in symptomatic ICH in previously disabled people. So we would just have that discussion. Next is rapidly improving symptoms. So early improvement doesn't mean that you're not dealing with a fluctuating stroke and somebody who may get worse again. I had a great case of this just a few days ago where an internal medicine doctor in one of our hospitals came in to work, normal, talked to the nurses, everything was fine. And then somebody noticed he was suddenly aphasic and he was talking gibberish, completely aphasic with right-sided weakness when I first saw him. While I reached out to his wife about contraindications, he started answering all the questions for me and suddenly became able to speak again. He got back to the point of just saying numbness on exam, but being a physician, he was able to say, but something's still really off. And so I tried to get him up to walk him. He could not walk. So we did go ahead and treat him. And lo and behold, we get the CTA. He had a non-occlusive thrombus in his M2. So giving him TPA was definitely the right thing to do. And he did get a little worse even during the TPA time. So I think remembering that just because somebody's almost better doesn't mean they're not going to just flip back the other way again. So we certainly want to make sure we're still treating rapidly improving but still present symptoms and only stopping if it's truly the resolved symptoms. Okay, so next is another question. I have a 65-year-old female with a history of strokes with residual aphasia and right arm weakness. And she had seizures after her prior stroke, not currently on any AEDs, who's presenting with speech changes. She was last normal 2.5 hours ago and had some witness what sounded like focal seizure activity of the right arm and was nonverbal at the time. On exam, she's drowsy, no new weakness, not answering questions appropriately, but unclear if it's worse aphasia from baseline versus confusion. Would you treat with IV Alteplase?
so this one is a little more controversial. This one is 58 yes and 41% no.
Okay. And that's what I was expecting. So this was, again, a real patient that I had about a week ago while I was making the slides, and I thought to include it more out of my curiosity. So in this particular patient, I actually did not end up treating, and her MRI did not show a stroke. But it shows you how hard these stroke mimic patients can really be sometimes, and that there really isn't always a right or wrong answer other than, and this one, it was kind of my gut telling me it was more of a confusion than an aphasia. And every time I talked to the family, they gave me another piece of, oh, but that sounds like her normal. Oh, but she does that. And kind of got to the point where I'm like, I just can't treat her. I am all for treating potential stroke mimics if I think that there's any chance they could be a stroke. And it, bothered me enough that I went back to check the MRI the next day because I'm like, oh, the gut told me not to do it and I didn't, but was I right or was I wrong? And I think it kind of highlights how hard these can be, but we always should be erring on the side of treating if we can't prove that it's not a stroke. And I kind of throw seizure in here with stroke mimics in my mind because, seizure at onset may be a little bit more likely than some of our other stroke mimics because sometimes it is an embolic stroke that's actually causing the seizure. But we still have to consider that if you can't really prove it's postictal, and if there is anything more than the confusion we had in that patient, if there's true new focal weakness, then we really do need to take those seriously and treat them, as well as any other stroke mimics like our complex migraines. Or sometimes there's that patient that you can swear upside down is functional and no way you think this is actually a stroke, and you don't treat them and you find out the next day they did have a little stroke. I've noticed that a lot more often in the younger patients because they can get that ratchety look to their weakness. They can get that functional appearance because their brains are healthier and trying to compensate in a different way than we're used to seeing. So I get very hesitant with that young complex migraine that you don't think is real, actually not treating them, because I've seen that happen quite a few times to patients and they really were real. So the complication rate of stroke mimics varies depending on where you look, but really it varies between 0 and 1%, as the highest ones that I've seen reported. So with that low of the hemorrhage risk and a potential for a disabling deficit, it makes sense to give these patients the benefit of the doubt and treat them. Okay, and our next question here. It's a 74-year-old female with a history of AFib on warfarin who is presenting with right-sided weakness and dysarthria. Her INR is 1.7 with a PT of 14, and the last known normal was an hour ago. Would you treat with IV Alteplase?
So this one we are about 70% yes and 30% no.
Okay. So for this patient, they are on warfarin, and in that situation, 1.7 equal to 1.7 or less, we can treat. So this patient was a yes, we could treat, and the PT less than 15, and the PT was 14. So this is a patient that should be treated with TPA because they are within the guideline range here. And those numbers, we do have some data to support, both from the Get With the Guidelines registry and the SITS database, that we're showing no increase in symptomatic ICH when patients were treated with those numbers. So with that level of safety, it's important to know exactly where those cutoffs are and to still treat those patients when we can. The red area here for our contraindications, we have that we shouldn't treat patients with platelets less than 100,000, INR greater than 1.7, which you got to love the flipping back between the less than and equal to and the greater than, because it just kind of makes it all more confusing for people to remember. And then our APTT greater than 40 seconds or a PT greater than 15 seconds. and that we really don't know, so that we shouldn't administer. And just to give an idea of where these numbers come from, they're not data study founded numbers. They're expert consensus is where these came from in the first place. And then everybody's kind of followed them ever since. There are times in which we have some case reports of them not being followed. And so there's 21 cases in literature review of people treating platelets less than 100,000. And among those cases, there was one symptomatic ICH, which would be 4.7%, which is still actually less than our quoted numbers of 6% bleed risk. And out of 115 patients treated with warfarin with an INR greater than 1.7, again, one symptomatic ICH, which at that point is 0.8%, and 164 patients with a prolonged PTT had 6 symptomatic ICHs, which is 3.6%. So while we have these numbers, I kind of think of those things when you get that patient with the PT of 15.2 that comes back 45 minutes into your TPA infusion. Do you stop it? Is that 15.2 a rounding error? 15 isn't a really solid number. So while technically by the guidelines, yes, you do stop that. But I have certainly had conversations with family that there is a slight elevation and their bleeding risk may be a little bit higher. But in reality, if you're 45 minutes into the infusion, when those labs are coming back, you probably aren't going to change that bleed risk anyway. Uh, and I know I should just be saying go along with the guidelines here, but it's certainly one of the things that I do fudge sometimes. You can try repeating the lab and consider re-giving it, or if it's a very, very minor number change, I think it's important to know if you have a devastating stroke in front of you that there are cases with low bleed risk in those tiny differences in the numbers that it may be worth considering that family discussion and still continuing that patient's treatment. But I wouldn't do it without letting the family know and being able to very well document those discussions and them wanting to proceed with that. Next, we have the history of anticoagulant use. So there's quite a few different ones that are mentioned in the guidelines here. The boxes get a little confusing, so I figured I'd type these ones out. And so the IV glycoprotein 2B3A inhibitors, while they say their safety of co-administration is not really well established with the first two here, they also have abciximab as a contraindication because we do have some study evidence of that. And if you're going to tell me that one drug in the class is a contraindication, but we don't really know about the other drugs in the class, at this point, I think it's safer to say we do not treat these patients until there is any safety data that came out that would make that opinion change. So for right now, to me, it is a hard no on any of this class of drug. The low molecular weight heparin, if they were giving a full treatment dose in the previous 24 hours, then you should not treat. But if it's DVT prophylaxis, you can treat. So that's just the important thing to remember there. DVT prophylaxis does not prohibit us from treating with TPA. And our thrombin inhibitors and factor Xa inhibitors, for the most part, we follow the last 48 hours, we do not treat. Because if you wanted to consider treating, you would have to have a normal APTT, INR, platelet count, eccrine clotting time, prothrombin time, or a direct factor Xa activity assay. And we can't get those realistically in the hospital in a timely enough manner in order to be able to treat patients. So it really is just the 48 hours. And there is some new evidence coming out. There was a study recently published that you can see down here in the right corner, in which the reversal of dabigatran in 80 patients showed that there was no bleeding complications when they treated them. So maybe at some point we'll be reversing these drugs and then treating. For right now, we'll stick with the 48-hour window of not treating if somebody has taken it in that time frame. And so dural and arterial punctures, I just kind of lump these together here. So dural punctures, it used to be within 7 days not to treat, but that has really changed to the idea of you can consider it and think about the potential risks and benefits, even if that lumbar puncture you've done has been within the last 7 days. So, maybe you don't want to do it for a numbness, but for a hemiplegia or aphasia, then it's worth taking the risk of a potential hematoma at that site. And again, you can monitor, hematomas can be drained, and that's the reasoning behind not treating a devastating stroke just based off of that. And I think arterial punctures, while we know if it's a non-compressible site, it's still saying uncertain for 7 days, within the 7 days, but we have a lot more experience, I think, now with this, with thrombectomies. I mean, we're giving TPA and giving groin punctures all the time. So groin punctures aren't necessarily a reason not to treat the cath, and that's our next area here. If a patient's in cardiac cath or cerebral angiogram, you would go ahead and treat them. If they've had a unilateral femoral puncture, you can just put a fem stop on. I've had them grab that and put it on in the ICU before giving the TPA, if that's feasible, or just getting it soon after if it's not feasible to get it in a timely manner right there. You can have somebody put pressure on the site until they can go get one. Nurses will not love you for that, but you can. So the groin puncture is certainly not a reason not to treat. If you have some sort of obscure non-compressible arterial puncture, then I would talk to vascular surgery and see if they think there's any chance that you could treat if the hospital you're in has that kind of support. But it's definitely something to consider for more significant strokes. And our next case here is a 45-year-old male who's inpatient for a colon resection 10 days ago, now with aphasia and right-sided weakness. Onset was 2 hours ago. Would you treat with IV Alteplase?
This poll is 90%, I'm sorry, 80% no, 19% or 20% yes.
Okay. Okay, and I can understand a slight amount of variability because I tend to go with the ask a surgeon. So while our recent major surgeries, at major surgery within 14 days, you can consider and you have to pretty much weigh your risks and benefits. For the most part, if I did not have a surgeon on board, I would not treat a 10-day post-colon resection. If I was able to talk to their surgeon and they said that they felt they could control surgical site bleeding should it occur, that would be a different story. But that's pretty much the question I ask on any major surgery and really any time frame is I like to be able to document whether the surgeon feels they can control any surgical site complications or not. If you don't have a surgeon available, then anything less than 14 days, it's well, not anything, but it's probably less advisable to go ahead and do that without somebody else saying that they could support the complications that we are not able to treat. If you have a hip replacement, that is likely going to be much more risk than if you have a knee replacement. A knee, you're not going to have bleeding out into the abdomen potentially and tracking out and having unknown large scale hemorrhage. The knee, yeah, you may have a complication that could lead to an amputation in worst case scenario, although unlikely, but usually there's drains and it can be handled. And most orthopedic surgeons, or at least in my experience, most orthopedic surgeons for a knee have said go ahead, and for a hip say no. But getting their input is really important here and making sure that we are not doing something potentially fatal for our patients. The nice thing is if they are within this 14-day window of a major surgery, they're probably still in the same hospital with the surgeon who did it, which makes our lives a lot easier in being able to reach them. And then our red here, our contraindication, is intracranial intraspinal surgery within 3 months. I would still strongly encourage talking to the surgeon if possible in these situations. With 3 months prior, there is a good chance they could be in your hospital without their surgeon. But spine surgeries, depending on what it is, I have had spine surgeries at a month and a half, 2 months, in which the surgeon felt the risk was low and was completely comfortable with me treating. So if at all possible, to reach the particular surgeon who did the surgery, you can still sometimes consider even within that realm. Intracranial, no, I'm not messing with it. If somebody operated on your brain, I don't think that's a risk anybody's going to give you permission to take, or I would want to take even if they did. And okay, so now recent trauma. So again, recent trauma within 14 days involving the head. As I just said, for a bleed in the brain, we really don't want to take that risk for the head either. So we're just going to call that a no. We have that down in red, acute head trauma in the last 3 months. We're not doing that. But if it's a trauma somewhere else in the body, really weighing what it is. If there's potential for intra-abdominal bleeding that would not be able to be controlled and potentially fatal in a minor stroke in which somebody just has some mild weakness, probably really not worth the risk. If there is trauma to a limb, a hand or a foot, and they're completely aphasic or completely plegic, that may very well be worth the risk. But having the conversation with both, in this case, your ER doctor, your medicine doctor, as well as the patient and their family, being able to well document the thought process as to why you did or didn't treat is really key. When you get into all these gray areas, that's what matters, is what was your reasoning? Were you actually doing something harmful out of negligence, or did you do something that ended in harm that was very well thought out and in the end maybe wasn't the best decision, but there's no way you could have known that? So just making sure these things are really well documented is so important. So our next question here. A 60-year-old male with a history of hemorrhoids who's presenting with flaccid weakness on the left side, onset 1 hour prior. He had a small amount of blood on the toilet paper 2 days ago when you ask him if he's had any bleeding, and no history of significant bleeding requiring transfusions. Would you treat him with IV Alteplase?
All right, we are getting our poll questions in. And we have so far 78% say yes and 21% say no.
Okay, and for this patient, I would definitely treat. Hemorrhoid bleeding can be contained. The thing that we're really worried about is the bleeding throughout the GI tract that we couldn't get to try to do anything to stop or even really be able to identify where it is. So the history of a GU bleed, not within the last 21 days, just a general history, is considered reasonable to treat, because if they're not having active bleeding, it's far enough away. There's no reason to necessarily believe whatever bled at that point is going to bleed again. I think one of the situations we often end up in is an unidentified GI bleed that the patient was stopped on their anticoagulation for, usually a year or months ago. And in that situation, if they were on warfarin, we don't know how well their INRs were controlled, they bled from something, and then they stopped and they've been fine for months, I don't see any reason we shouldn't treat them. I do tend to mention to them, if they didn't figure out what that bleeding source was, that there is a chance it could bleed again, but less likely given you're not on a daily regular blood thinner. It is in your system for a very short period of time here. And then if they have active bleeding within the last 21 days, then that's considered high risk and shouldn't treat. And when we're talking about the structural GI tract malignancy portion here, that really means your esophagus, your stomach, small intestine, colon, not necessarily your other organs. You do have to consider, if you have a liver malignancy, that usually is a situation in which I wait for labs to make sure their INR is normal, because they could be, have a coagulopathy related to their malignancy, and that's something you certainly need to consider. But if not, say it's a pancreatic tumor or something else, those are patients you can treat, because the concern is that malignancy bleeding and being unable to contain it because the GI tract is so large. If you fill that whole tract with blood, that's potentially and likely going to be fatal for the patient. Okay, next question. We have a 24-year-old female with a history of hypercoagulable state who's not on anticoagulation. and is 30 weeks pregnant, is presenting with aphasia and flaccid right-sided weakness onset 45 minutes ago. Would you treat her with TPA?
All right, it looks like we are at 91% say yes and 9% say no.
Okay. So, female issues here. I kind of thought it was very interesting when I saw menstruation in the guidelines. I was like, do we really not consider treating women just because they have their period? But then you think about it, and there are some other extenuating circumstances that can come along with that. Obviously, regular menstrual cycles are never a reason not to treat a woman, and usually something you would not even know about because people don't ask that, or at least I don't think anybody asks that when they're consenting for TPA. But if you ask the general question, like I often do you have any history of bleeding issues anywhere in your body? We will sometimes get the answer that they have significant vaginal bleeding or they have very heavy periods. And then it does take kind of finding a little bit more out about what they mean by that. Somebody who has fibroids who bleed, not a reason you can't treat with TPA, but if they get anemic from it and they have significant issues, you may want to weigh, is this just a numbness? Probably not worth treating them. If it's a significant deficit, then certainly something to consider pursuing and a reason to get gynecology on board. For the most part, what a gynecologist has always said to me is I can take a uterus out. If I can't stop the bleeding another way, I can just take it out. So the idea of a really disabling stroke limiting treatment to women because of these types of issues, it's not really the same as the GI tract question. When you can bleed out into your GI tract with all the extensive amount of small bowel and things to find, you may not find the bleeding. If you know it's coming from the uterus, it's right there. OBGYNs know how to handle this. So really, that's not a good reason not to treat these patients for significant strokes, but a good reason to grab your OBGYN colleagues to get some backup and support. And pregnancy, there is not great data. You can't enroll pregnant women in trials very easily. Nobody wants to find out if a baby's going to die or not from a medication or if the mother is going to. So these are just really hard things to get good, solid data on. And there is, the thought that there may be uterine bleeding that could lead to miscarriage or loss of children, and people get really hesitant to treat pregnant women. I personally think and I think most patients think if you can't take care of your child, if you have other children, mother before fetus, because the mother is actually here and present, and we do need to think in terms of what they want there and be very open to treating pregnant women. And we have a little bit of research. I found this one literature review article that looked at all the publications through 2017. This is from maternal fetal medicine literature, not from neurology. But they couldn't find any randomized trials, as I just mentioned, but they did show one prospective study, and then most of the rest is just case reports and various things they found. But of 141 pregnant women who had a serious thrombotic event and were treated, there was 4 maternal deaths, 12 major bleeding episodes, 13 mild to moderate bleeding episodes, 2 fetal deaths, 1 child death, 9 miscarriages, and 14 preterm deliveries. So the caveat that goes along with this is it often was really sick mothers in the first place that ended up in these situations. And the maternal deaths, fetal deaths tend to go together as far as the poor outcomes of the overall case. So the consensus they had, and what I think we see in these percentages not being all that far from our typical 6% bleed risk, is we do know there may be some additional risks, but we should very much so still consider treating these patients if they have any sort of disabling symptoms, letting them know that there is a potential for pregnancy-related outcomes that would not be desirable is definitely something we should be saying and discussing with them, but not offering treatment would not be doing right by the mother, who is really our primary patient at this point. So conversations need to be had around pregnant women, but we should be weighing the risk benefits and certainly treating the disabling symptoms and thinking that through. And if there's questions or concerns, calling on our OBGYN colleagues again to help participate in that decision-making process. Okay, so here I kind of lumped together all the different vascular issues. So extracranial cervical dissections, reasonably safe. We should probably treat them as they put it. Really, there's no evidence to say that we shouldn't treat them, so we should just go ahead and do that. Intracranial dissections, a little harder because you do have this potential risk of having subarachnoids with those, and we really just don't have a lot of good data on how high that risk actually is. The thing with that, though, is I don't know how often you really know about it. I guess if you're getting that CTA before your TPA decision, but we don't practice that way very often. So I know I personally have treated intracranial or MCA dissections without knowing about them until afterwards, and did not have any bleeding complications from them. So it's something I think if you did happen to know, you really have to weigh your risks and benefits here of actually treating those. And I don't know that I have a real clear answer on what's right in that case. The unruptured small to moderate size aneurysms, which is less than 10 millimeters, if they're unruptured, unsecured, really your incidental aneurysm that you find, is probably reasonable and probably recommended, which the reasoning behind that is if it's unruptured and unsecured, there's no reason to believe that there has a higher chance of it rupturing at the moment that you're giving TPA or those few hours there. As long as you're keeping your blood pressure controlled, I mean, there's no real risk unless it actually ruptured with TPA in their system. And the likelihood of that just doesn't seem that high. So I have never hesitated on one of these small, unknown incidental finding aneurysms to go ahead and treat them. The giant aneurysm is a little different because a lot of giant aneurysms do have some kind of very hard thrombus in there, or often do, and the TPA could potentially loosen that, send off, and have more stroke related to them. So that's the concern with those giant unruptured, unsecured aneurysms that we don't know about. And that one's a little harder. I think you have to really weigh the risks and benefits, how bad the symptoms are, and the overall situation. And we don't really have a clear answer. As they say, it's not well established. We don't really know. Other vascular malformations, again, something that we don't have a lot of good data for, but shouldn't automatically rule people out. And I think these are places where we, as we saw on that first slide, that aneurysm was the 50% variability in neurologists. And I'm sure we see a lot of variability with all of these vascular malformations because it really, an AVM that's been monitored, incidentally found, never caused any issues, just kind of there and never bled, and a really bad stroke, I would still treat that. Again, unless something happened to happen at that same time, there's no reason to believe that the TPA itself should cause a bleed from the AVM. And these are just things that I can't give you good data. I can't tell you what you definitely should do. I think a lot of it comes with what you're comfortable doing and what risks and benefits the risk the patient's willing to take and how big that potential benefit is based on how debilitating the symptoms are. Do you want to take that risk for a numbness that's not affecting anything? Well, you probably don't want to do that anyway because it's not disabling. But you have to really think about what you're putting, what decisions you want to make here and what the patient is willing to risk. And our red section, aortic dissection, we all know that's bad. We don't want to do that. So that I'm not going to negotiate. Okay, cardiac issues. So an acute MI, treating the stroke with Alteplase doses for stroke and not for STEMI, are what we should be doing, and then sending them to the cath lab. So that's a reasonable course of action, and I feel like most people are pretty comfortable with that. The recent MI, so somebody who had an MI in the last 3 months with this whole theoretical myocardium rupture, again, it's more theoretical that concern was there, which is why these guidelines have changed more to saying that this is reasonable for both a non-STEMI and a STEMI involving the right and inferior myocardium, and then may be reasonable for that left anterior myocardium. But really, if you have a significant stroke, I wouldn't let the heart attack be the reason not to treat them in this time frame. I personally have had a patient have a hemopericardium after, not related to a known recent heart attack. Maybe they did have one that we didn't know about. And in talking with the cardiologists, they can drain them. It's not necessarily a fatal event to have that happen, and it's certainly something they can monitor with echoes. And that patient I had didn't actually need any sort of intervention. They just did serial echoes, and it went away on its own. So not something that should be scaring you off right off the bat. The next one here is acute pericarditis. And in this situation, they're saying if the symptoms are very severe, something to consider along with cardiologist. And it's not something I would want to do without discussing it with their cardiologist. If they're in the situation, they're likely in the hospital already, and that team should be available to really discuss the risk versus benefits, and that'll depend on how severe or mild the symptoms were. A left atrial or ventricular thrombus. Really, if they have this and you know it, they're probably going to be anticoagulated and you can't treat them anyway. Otherwise, I don't know how you would know it. So I just think it's an interesting thing to put in here because I don't know when you'd be in the situation of actually being able to give TPA to one of these patients. So if you are in that situation, though, then they say it is worth taking the risk in a severe case. I do notice that we are getting close on time, so I'm going to try to breeze through some of these to get to a few more of the more important ones I wanted to hit. Other cardiac, you're just kind of, again, can consider with the myxoma and fibropapillary fibroblastima. We don't treat with infective endocarditis because of the bleed risk. And we could throw in this question. So we have a 56-year-old male with lung cancer who's presenting with right-sided weakness and dysarthria. Last known normal was 3 hours ago. He's on chemotherapy, but his CBC, PT, INR are all normal. Would you treat with IV Alteplase?
It looks like we have 100% yes on this one.
Good. So malignancy in and of itself is not a reason for us to not treat patients. If they're on chemotherapy, we need to think about those labs. But life expectancies aren't perfect. So even though they say a greater than 6-month life expectancy, I think if they're having a significant event, they want to be treated and do everything they can, we should be giving them that choice. Extraaxial intracranial neoplasms are meningiomas. We can treat those. True brain tumors here, the intraaxial, we don't want to be treating them because of that risk of hemorrhage. That would be our contraindications. Ophthalmological conditions, you may lose vision in that eye. I've had that conversation many times. If you lose vision in that eye, but you can't speak or you can't move, most people would be willing to lose vision in one eye if they could potentially save the other deficits. It's going to depend on what the deficits are and having that conversation of what risk they're willing to take. So now mild strokes. This one is probably the one point that I really don't go along with in the guidelines because they're calling a mild stroke 0 to 5, but non-disabling. I have yet to meet a patient with a 5 NIH whose symptoms are not disabling. I don't believe that exists. Now, if you want to say a patient with a numbness is really the only non-disabling, because any level of weakness that's true weakness that we could give points to on an NIH is going to affect your functioning. People can argue a left hand that's non-dominant, but it depends on what you do. Not everybody's career depends on writing. If you do something that requires 2 hands, that can still very much so be disabling. So I tend to leave that, would your life be affected and your ability to function change based on this, to the patient and letting them tell me. If you're dealing with a pianist, that left hand being weak, their career is over. There's things that still matter despite these numbers. And putting an NIH in here just always bugged me because I think non-disabling is not defined by a number. And we have to really consider when we're not treating somebody if this is truly going to not affect them in the long term and let them be a part of that decision. I had a good story here, but I'm going to save it because we don't have that much time. But if anybody wants to know my non-disabling story, let me know, and I'm happy to share it in email. Okay, our last question. Our 65-year-old male with a history of traumatic subdural hematoma in his 20s, who was presenting with right-sided weakness and aphasia that started 1.5 hours ago. Head CT is normal. Would you treat with IV Alteplase?
The results are 78% yes and 22% no.
And that's actually more than I expected to say yes. I am fully a yes on that, but technically by the guidelines, it is a history of an intracranial hemorrhage. So it says no, but that old history of a traumatic subdural, and if the CT is normal and they said they had some sort of brain bleed or injury a million years ago, but yet their head CT looks just fine, I still treat them. And that, I think, is a difference of opinion. This is one of those areas where I guess the guidelines say no, but I would say there is not a solid right answer, because I can see those being uncomfortable treating, but I'm certainly one who would go ahead and treat. So I actually didn't expect quite so high as 70%, but I like it. And so we'll also just quickly mention the cerebral microbleeds. If you have a very high burden, you may have a higher risk of ICH, and it's certainly something to consider in making the decision on whether to treat or not. We don't really have, again, a solid answer as to if that's really enough not to treat. But if somebody has a huge cerebral microbleed burden, I feel like a lot of times they're presenting with a bleed, and we often see that as an actual bleed. But it's something that you can kind of consider in the process, but I also don't look back at somebody's MRI before making that acute decision. So not something that factors into my day-to-day TPA decision making. One other thing I wanted to make sure we talk about with the hemorrhages here, obviously we know we don't treat an ICH, subarachnoid hemorrhage. If we have a high suspicion and you think by that story, sounds just like a subarachnoid, you really do need to have extreme hesitancy in treating them with just a normal head CT. They certainly can have the very start. The blood's not quite visible yet. We don't see it. And those can be obviously fatal if we are to treat those patients. So not every headache is a subarachnoid, but if they have a really, really classic story, that is considered a contraindication. Recent strokes within the last 3 months, the concern is that they're going to bleed, so that's considered a contraindication. Now, there are case reports of patients being treated within that time frame without complications for really small minor strokes and then having a bigger stroke. I've seen case reports up to 24 and 48 hours of patients getting treated with TPA despite having that recent stroke and being okay. So now there may be situations in which patients can be treated in these realms, but I certainly think in our position of practicing, telemedicine, limited accessibility to things, this isn't something we should be doing. We should be kind of going by the guidelines on this one. If you know someone had a stroke in the last 3 months, not treating them. Just some other points that are in there: treating sickle cell, treating a hyperdense MCA sign, and that if somebody's on illicit drugs, that's not a reason not to treat them. So the only thing that wasn't referenced in there was the guidelines, which is where most of this came from. Unfortunately, I can talk about guidelines for forever, and we're already over time, so we don't really have question time. If we have things in the comments, I am happy to answer them, via email and have further discussion on any of these topics here that people do have questions, thoughts they want to share, anything like that on. So we can certainly have further discussion if there is any. I haven't been able to see the question tab so far. So I'd like to thank everybody for joining today. And as I said, don't hesitate to reach out if you have any questions or anything you want to talk about. And have a good day.